Okay, so good evening, everybody. Welcome you all on this Saturday evening. I'm in this interface. I'm not actually able to see how many of you have logged on, but I guess it's about time. So I'll start with my presentation. So I wanted to talk a little bit about trends in antiplatelet therapy. I'm Dr. Saujatya Chakraborty. I'm an interventional cardiologist, and antiplatelet therapy is something which day in and day out we have to practice. It's almost ubiquitous in our use. So, what exactly is the need for, just to give a setting of what we are going to discuss today? So, what exactly is the need for antiplatelet? So, you see what happens when an MI or an acute coronary syndrome occurs is that there is a break in the endothelial lining of the vessel, coronary artery vessel wall, leading to plaque erosion or rupture, because of which the plaque contents, that is the fat which is embedded in the atherosclerotic plaque, it gets directly exposed to the bloodstream, and because of this direct exposure, there is thrombus formation because of activation of the coagulation pathways, leading to compromise in the luminal diameter, leading to say interruption in blood flow of the coronary artery tree. And the larger is the extent of this, more is the vessel myocardial damage, leading to increased severity of the acute coronary syndrome. So just again to show, so what actually happens is that there is platelet plug formation. So at the site of plaque rupture or plaque erosion, what happens is that the coagulation pathway is activated, and because of which these nodular platelet plugs start forming. And if platelet plugs progress, then they can lead to formation of either red thrombi or white thrombi followed by red thrombi. And these thrombi can actually occur not only at one part, they occur throughout the vessel wall and sometimes can completely occlude your artery and lead to cessation of blood flow. So that's why we use antiplatelets, because the starting point of these coronary syndromes is formation of a platelet plug. So what we generally do, another thing which we have to conceptualize is that we generally do angioplasty, we put in stents. So after putting in stents, you can actually plaster the atherosclerotic plaque to the vessel wall, and you can open up the vessel again. When the stents have, after the stents have been developed over a period, deployed over a period of months to years, what happens is that these stents get endothelialized. What does that mean? It means that over the stent struts, there is a thin layer of endothelium which again grows, and covers all the stent struts. At least that's what is supposed to happen. And then after a certain period of time, the stent struts are not exposed to the bloodstream at all. So if that happens, that is very important and that is desirable, because stent struts are foreign bodies. When they stop getting exposed to the bloodstream, chances of stent thrombosis forming over this foreign body gets reduced. So this repair of the vessel wall can sometimes be very florid, and it can actually lead to, if it is very florid, so you can see that the stent struts, these shining things over here, these are the stent struts, and over it, this thickened intimal hyperplasia has occurred. If this occurs to a great extent, it can actually again cause luminal loss, and that's why over a period of years, you can see development of restenosis inside the stent, what we call as in-stent restenosis. Something far more worrying than that is this image over the right side. So sometimes what happens is that you can have stent thrombosis. So this reactionary tissue overgrowth over the stent struts can sometimes also be associated with angiogenesis, new angiogenesis, and new atherosclerosis. That means again atherosclerosis inside this reparative endothelial lining, and that can again rupture. So these are again the lipid-rich new atherosclerosis which has found, and this can rupture, expose itself to the blood vessel, and you can again have stent thrombosis. So this stent thrombosis is something that we are very afraid of as interventional cardiologists, because this is a lethal event most of the times. The MI is hemodynamically significant. It can be ST elevation MI, and fatality rates are very high in cases of stent thrombosis. So stent thrombosis is something that we are very worried about, and that's why we try to give as powerful antiplatelet agents as possible, so that formation of thrombus, chances of formation of thrombus come down. Of course, this comes at a cost of increased bleeding because more are the antiplatelet therapy you use, more is the chance of bleeding. So in our practice as cardiologists, antiplatelet therapy is required definitely in patients who have stable coronary artery disease, so that we can reduce the chances of thrombosis and reduce the formation of the chances of thrombus formation and reduce chances of spontaneous MI down the line. Of course, we need antiplatelet therapy when a patient presents to us with acute coronary syndrome. And down the line, when these patients have recovered from acute coronary syndrome or have undergone one or the other revascularization strategies, PCI or bypass surgery, or even if they have been managed medically and have a remote history of MI, these patients are called fall into the category of chronic coronary syndrome. So in these patients too, we require antiplatelet therapy. What are the constituents of this antiplatelet therapy and how intense this antiplatelet therapy will be in these three groups is the subject of intense research, intense speculation, because as I said, you can't just keep on increasing the intensity of your antiplatelet therapy because that comes at the sort of cost of increased bleeding, and bleeding is something that can actually be fatal. It can't be stopped because it's not a localized bleeding all the time, it's a generalized use, like say intracranial bleeding or gastrointestinal bleeding. It's very difficult to stop once bleeding starts. So bleeding is not an innocuous side effect, it can be actually dangerous. So as I said, bleeding is dangerous, but so is stent thrombosis, a highly fatal event. So you can see these ugly looking pictures. So basically there was a stent implanted in the left anterior descending artery. This angiogram in the top left shows visible thrombus which has formed inside the stent layer. This can also be seen in the OCT layer, OCT findings, where you can see that layer of thrombus has formed, and this has led to compromise in the luminal diameter. The lumen is not big and circular like it's supposed to be. And right here, the B5 image, you can see a big chunk of thrombus which has formed over this stent struts. So stent thrombosis is something that we have given to the patient. It is an iatrogenic or so-called iatrogenic complication, and this is something that we have to avoid at all costs because these events are generally fatal or can actually be very challenging. So in the discussion of what antiplatelet therapies and intensity of antiplatelet therapies to use, we should also remember that one of the important factors is from the clinical standpoint. So I was showing you the angiographic findings. So one important factor which predisposes to events is diabetes, especially in India. So India is supposed to be the diabetes capital of the world, and we all see that diabetics somehow or the other are prone to more cardiovascular events, whether they have an acute coronary syndrome or whether they undergo successful revascularization procedures as well. So diabetes is something which complicates management as far as our practice as cardiologists is concerned. So I'll be talking basically today about three different trials because you see there is lots of discussion, lots of things to be discussed about antiplatelets. Three different trials we have chosen so that three different types of trends that have come up, three different types of usage of antiplatelet therapies we can discuss, especially with respect to the use of ticagrelor, which is a newer congener of clopidogrel, which is the older molecule, and both of them are P2Y12 inhibitors. So I'll start with the THEMIS study, which has used ticagrelor and aspirin in patients without MI but with stable CAD. I'll go on to use two trials where different types of dual antiplatelet strategies have been used in patients with acute coronary syndromes. So this is the oldest trial. This was actually published in NEJM so in 2019. So the THEMIS study. So the name of this study is a THEMIS. It's a double-blind randomized controlled study. So basically, simply put, patients with stable coronary artery disease. How was stable coronary artery disease defined? Either a history of previous PCI or CABG, or a documentation of stenosis more than 50% on coronary angiogram, along with diabetes. So patients with stable CAD who were diabetics, but who did not have a previous history of MI or stroke. This is important. So patients without a history of MI or stroke, but who had either documentation of coronary artery disease or a history of previous PCI, which was putatively done for stable CAD in the past, were taken up for this study. They were randomized to either receive only aspirin or a combination of aspirin and ticagrelor, and follow up for a period of at least 3 years to see whether the primary efficacy outcome, that is death, MI, or stroke, was more in the ticagrelor arm compared to the placebo arm, or vice versa. So uh, this study was actually restricted to ticagrelor. The other P2Y12 inhibitors like clopidogrel or prasugrel were not used. So you had two groups of stable CAD diabetics. In one group, only aspirin and placebo was given, and in the other group, ticagrelor and aspirin. A follow-up of 3 years. So this trial was actually conceptualized to add to the evidence base of use of dual antiplatelets to decrease the vascular risk in different subsets of population. So you first had charisma, which actually also took patients of MI and stroke and randomized them to dual antiplatelet or single antiplatelet. You had the Plato trial, which actually brought ticagrelor into FDA approval and use, where ticagrelor was compared to clopidogrel in patients hospitalized for ACS. You had the Pegasus TIMI trial, almost similar to the THEMIS trial. However, this had patients who had a history of MI plus a high risk feature where ticagrelor and aspirin were compared to aspirin. And now you have diabetics with stable CAD who are randomized to either dual antiplatelet, including ticagrelor, or a single antiplatelet. So this is a classic types of the patient characteristics. Not so many of them were hypertensive. So actually, 56% had multivessel coronary artery disease, and almost 92% had stents in patients with a history of PCI. 12% had CABG. So this was the patient population. So you can see here that the renal dysfunction was not that high. eGFR was around 75 in patients with a history of PCI or without a history of PCI. So the primary endpoint of death, MI, and stroke. After the completion of the study, it was found that the primary endpoint, the blue line actually, the primary endpoint was lesser in the ticagrelor group compared to the placebo group. This was sustained over a period of 54 months. So addition of ticagrelor to aspirin was actually successful. Was actually did show a decreased chances of events. Although the absolute difference was not much, but yes, there was a difference with tending towards benefit for ticagrelor in this trial. So however, the difference in efficacy was not very significant or much different, although, yeah, you can find some statistical significance in these results. So a hierarchy test was performed. So actually, hierarchy tests are performed to see what actually causes all-cause mortality. So the THEMIS trial actually met its primary endpoint, that it showed a decrease in death, MI, and stroke, but it was not actually able to show this in the hierarchy test as well. So if you see here, comparison of the ticagrelor and placebo group with respect to cardiovascular death, the p-value is not significant. The p-value is definitely significant as far as MI is concerned, no, and ischemic stroke is concerned, but not for all-cause death. So not much difference in all-cause mortality as well as cardiovascular mortality. There were trends towards benefit of ticagrelor in almost all the subgroups specified, but if you can see, lots of these subgroups have the hazards ratio confidence intervals crossing over to the other side. So not much statistical strength overall in the findings, although there was a trend towards improved outcomes with respect to ischemic outcomes with ticagrelor. The important thing that about THEMIS is that so is that statistically significant benefit of ticagrelor was there compared to placebo in actually patients who had undergone PCI, and this benefit actually remained for a maximum of 6 years post PCI. So 3 years before randomization and up to 3 years after randomization. So up to a period of 6 years actually, there was a significant benefit of adding ticagrelor to aspirin in this subgroup of diabetics who had PCI. So safety outcomes. This is something important. So although the efficacy outcomes are good, but as you can see, patients had more chances of major bleed with ticagrelor compared to placebo. Almost the hazards ratio, so almost 2.5 times increased chances of any type of bleed. Different types of classifications of bleed are there, and ticagrelor had a higher chance of bleed compared to placebo, which is actually around 2 times more than placebo. So it's not that it can be ignored. So this trial had a pre-specified subgroup analysis. So they, although among all the patients who were randomized with stable CAD and DM and diabetes, around 11,000 patients actually had a history of PCI, and this was the subgroup analysis which was done to see whether actually the benefit was different or same in this population compared to the overall population. So actually, this subgroup analysis was able to show some better results, and this patients with a history of PCI actually fared better with respect to the primary efficacy outcome compared to the patients without PCI. So patients without history of PCI, the results were almost same in the two arms. However, patients who had undergone PCI had a more benefit with respect to ischemic outcomes when ticagrelor was added to the overall combination. Of course, again, this came at the expense of increased bleeding. So this basically, again, this slide again, overall simply it states that the chances of bleeding, whichever bleeding classification you use, was around 2 times or 2.5 times more compared to the use of placebo. So actually, this subgroup analysis led to the hypothesis generation that actually the events prevented or caused for 1,000 patients treated with ticagrelor or aspirin. So you can see here that patients with a history of PCI had more chances of benefit. So there was more chances of benefit with respect to ischemic endpoints and net clinical benefit compared to patients who did not have a history of PCI. In his patients who did not have PCI, actually you see that there is not much of a difference. Actually, the only thing which occurs is that a net negative clinical benefit is seen because of increased chances of bleeding in these patients. So the result, the message is that patients with a history of PCI diabetics actually have more chances of benefit when ticagrelor is added compared to monotherapy with aspirin only. So this identifying patients who are at higher risk of ischemic events and selecting them for intense therapy with ticagrelor is something which has been a recurrent theme in all antiplatelet discussions over the years. So this is something that from all trials we try to pick up, which is the group which benefits more from ticagrelor use. MI, myocardial infarction, is a main risk driver. So, like the CDOT study shows, patients with type 2 diabetes with coronary artery disease who had a history of MI or stroke had a higher chance of mortality and adverse outcomes compared to those who did not have MI. And these are perhaps the patients who can be taken up for incorporation of ticagrelor into their treatment regimens. So there are some uh, important message which comes out from Pegasus TIMI and THEMIS is that patients with a history of MI, stable CAD patients with diabetes who have a history of PCI, these are perhaps the subgroups of patients which benefit more. Another underlying result which was seen in both Pegasus and THEMIS is that other than bleeding, another problem with ticagrelor is actually discontinuation of therapy. So overall, 29% discontinued ticagrelor in Pegasus and 34% discontinued ticagrelor in THEMIS. This is an important practical point for practicing physicians as well, because you can understand you put your effort and find out the patient who is going to benefit the most, and you prescribe a costly therapy like ticagrelor, which is costlier than clopidogrel, but you can actually expect that 30% of them will drop off. So that is an important consideration. If you think that your patient is going to drop off from ticagrelor, it's better to put the patient on clopidogrel. The reason for drop off was not only bleeding but also dyspnea, which actually we all have seen in clinical practice. Dyspnea is something which is a nagging problem, not very frequent, but every 1 in 5 patient maybe comes with a problem of dyspnea. So, on-treatment analysis shows that in patients with history of PCI, there was even more a reduction in all-cause mortality compared to the intention to treat analysis. So, just to summarize the discussion on THEMIS, so whom do you treat with ticagrelor and aspirin dual antiplatelet therapy? So these are THEMIS-like patients, that is type 2 diabetes with coronary artery disease with a high thrombotic risk, which means a history of PCI, recent PCI or remote PCI, and who have and basically who are something what we call as frequent flyers, patients who have recurrent episodes of either restenosis or acute coronary syndrome and keep on coming to you for multiple procedures. So these are patients at a higher thrombotic risk and low bleeding risk. So patients with low bleeding risk, there are various ways that in by which you can actually classify as low bleeding risk. So there are bleeding risk scores like DAPT, Precise DAPT, and Paris. However, these might be cumbersome for routine use. Clinically speaking, patients with an at older age, frail, who are frail, lower body weight, have a tendency to fall, have abnormal renal function. These are some of the people whom we classically consider to be at a higher risk of bleeding. And if these factors are not there, and if there is a history of PCI, then actually there is a good case for starting ticagrelor and adding ticagrelor to aspirin. So of course, your job becomes easier if there is a previous history of bleeding with prior exposure to dual antiplatelets. Of course, in those patients, you cannot substitute clopidogrel for ticagrelor. So clinical judgment still remains. It's an individualized therapy. You can, in patients in whom you are thinking of adding dual antiplatelet because of a higher thrombotic risk, but who have a lesser chance of bleeding risk, are always good candidates for ticagrelor. However, if there is doubt, don't go with stronger antiplatelet therapies. Keep it simple and use lower strength or single antiplatelets. So, how to treat non-PCI patients? At least this trial showed there is no doubt about that. Try to avoid using ticagrelor and aspirin. Continue with aspirin. Of course, in certain patients, you can individualize, go for ticagrelor or even clopidogrel. So, this is the message from this first trial in patients with diabetes and stable coronary artery disease. You can think of adding ticagrelor, of course, if you are very sure that bleeding risk is minimal in these patients. So this is what the THEMIS trial demonstrates. So patients with chronic coronary syndromes, history of PCI and CABG, who conform to the THEMIS population, can actually be taken up for ticagrelor dual therapy, especially if they have a history of PCI. Patients who don't have a history of PCI, it's better not to add ticagrelor to the overall regimen. So that is one important message from that trial. Now switch another important, clinically important trial, which is relevant for clinical decision making. So this is the topic trial. So we all know that after an acute coronary syndrome, suppose we have a patient whom we have done a PCI, and then we have we want to start the patient on ticagrelor and aspirin. So because ticagrelor is a costly therapy, we have seen that there is discontinuation. Is it possible that down the line we can substitute with ticagrelor for good old clopidogrel? That will reduce cost, that will improve compliance. However, this can only be done if efficacy is still equal and we don't put the patient at increased risk for stent thrombosis down the line. So this is what the investigators actually put to test in this trial. This is the topic trial, which was actually presented in 2017 Euro PCR. So we all know that newer P2Y12 blockers are first initial line treatment of after coronary syndromes, and generally we put them on 1 year of dual antiplatelet as a default strategy. But does it mean that we have to continue the newer anti P2Y12 blocker for 1 year in totality, or can we substitute it for clopidogrel down the line? We know that newer P2Y12 blockers like ticagrelor or clopidogrel have a higher ischemic benefit in the early phase, but down the line, where chances of events goes down, there is a bleeding hazard which takes over, and this takes over mainly in the chronic phase. So, is there a sweet spot where we can switch over from ticagrelor to clopidogrel to reduce the risk of bleeding and maintain ischemic benefit? This was assessed in the topic study with 1 month of potent dual antiplatelet followed by aspirin and clopidogrel for a year. So this is what they did. ACS patients undergoing PCI, they were randomized to either an unchanged combination, that is aspirin with ticagrelor or prasugrel for a period of 1 year, or they were placed in the switched DAPT. That means after a month, the patients were switched over to aspirin and clopidogrel, and ticagrelor or prasugrel was removed. So this was a 1 year follow-up, and the primary endpoint was death, urgent revascularization, stroke, or bleeding. And secondary endpoint was each component, and especially all bark bleeding. So this trial was a small trial. Actually, it was a single-centered trial, and so a modified intention to treat analysis was used, and so around not many patients, 646 patients randomized, around 323 patients to either arm, and actually for analysis, 322, 323 patients. So not a very big trial, but however, a practically important trial for us, and that's why we are discussing it. So what are the essential results of this trial? So actually, what this trial showed was that I'll skip this procedural characteristics. So basically, this trial showed that strategy of switching over to clopidogrel was able to show a statistically significant benefit with respect to the primary endpoint. So the primary endpoint was actually a combination of revascularization, stroke, as well as bleeding, along with death. So all these events were statistically less if we switched over to clopidogrel compared to if we continued with the newer antiplatelet along with aspirin. Ischemic endpoint, any ischemic endpoint. So this was there was actually no difference for ischemic events. So when we go down to only ischemic events, there was no difference in ischemic events. However, the rate of bleeding was more in patients who are continued on ticagrelor or prasugrel. So this is an important message. All bark bleeding. So bark bleedings are basically, it's a categorization of bleedings given by the ARC consortium. So all bark bleedings were actually more in patients who with unchanged dual antiplatelet compared to those who were switched to clopidogrel. So this is just a tabular representation of the same. So this study was single label and open single center open label study. However, they concluded that in patients without adverse events 1 month after a stented ACS, a switched DAPT is superior to an unchanged DAPT strategy to prevent bleeding while maintaining the same ischemic benefit without increasing the risk of ischemic events. So after a month, you can actually switch over from ticagrelor to clopidogrel so that you can both reduce the chances of thrombosis as well as maintain less chances of bleeding going on. So it's a kind of a halfway house. It's a kind of a middle path where you try to get the benefit of both the strategies. So if you plan to do this in your patient, you have the topic trial, which you can fall back and you can use as a reference for justifying your therapy. So this is a new strategy in which you can switch over from potent P2Y12 to clopidogrel after 1 month if the patient is doing fine and has not had any complication. So the essential to remember is that for 1 year, if there is you can actually try and switch over from clopidogrel after 1 month if the patient is doing fine. So what are the results of this strategy? If you switch over, there is less bleeding and there is no difference for major adverse cardiac events. This is for a period of 1 year because this we can only conclude for a period of 1 year because that was the trial duration. So these are important clinical implications for practicing cardiologists because you reduce bleeding and also in Indian population you reduce stroke. Lastly, I will come to this is the last trial that we'll be discussing. So this is the Twilights trial. And although this is the last trial, this is the trial I think which has made the most noise in recent years. And this trial still continues to be a topic for discussion. This was actually published in September 2019. So this was the Twilight study. So the Twilight study was actually conducted by investigators from Mount Sinai in New York. So Mount Sinai, the team over there, they actually do lots of complex interventional cases. They try lots of new therapies. They are very courageous with their strategies. I myself actually worked there for a few weeks, and I know that it's a very high volume center, and they do lots of good quality work. And they were actually brave enough to go ahead and do this study. What they did in this study was very interesting. What they did is that uh, rather than using aspirin and ticagrelor for a full duration of 1 year, as the guidelines suggest, they actually stopped aspirin after 3 months and continued ticagrelor for a period of 12 months. This is contrary to established practice where we actually try to stop the P2Y12 inhibitor and continue aspirin lifelong. So this is actually a disruptive sort of strategy which they followed, and they actually were brave enough to stop aspirin and continue ticagrelor monotherapy. And then they tried to see what were the benefits and what were the side effects, whether ischemic endpoints were better or same, or whether bleeding risk points were reduced. So a very courageous study. So they tried to in patients with ACS who underwent PCI, they tried to find out the primary endpoint, which was bleeding. So actually, this is a study which used bleeding, an adverse event, as the endpoint at 12 months for ticagrelor monotherapy. The other things which were also looked at were all-cause mortality, MI, and stroke, as well as MI, stent thrombosis, and stroke separately. And they were actually able to find that the composite endpoint of bleeding was actually much higher if the aspirin and ticagrelor were continued for 12 months, which was 7% compared to only 4%. So actually a 3% absolute reduction in bleeding when you remove aspirin from the overall combination. This came actually at a no loss of ischemic event. So you can see that MI or stroke were same, 3.9% in both the arms. And individually, MI was same in both the arms. Stent thrombosis was same, zero point 0.4 versus 0.6 in both the arms. And of course, although stroke, it was not powered for stroke. So the stroke was a little bit higher. So that's why this trial has become so famous. They concluded that a short duration, 3 months of dual antiplatelet followed by ticagrelor monotherapy for 12 months results in less bleeding compared to longer duration DAPT among patients undergoing PCI with a drug-eluting stent and at high ischemic or bleeding rates. So ischemic rates met criteria for non-inferiority. So you can understand that this actually is a great advantage, and it's an interesting finding that helps advance our understanding of the optimal duration of antiplatelets. So actually, this trial was able to suggest that maybe we can just stop aspirin, do away with aspirin, and continue ticagrelor. So there can be questions that whether they took up actually simple patients for their study and excluded complex type of patients for their study, and that's why they were able to find no loss of ischemic benefit. So that's why there were two interesting sub-studies which were conducted on the Twilight results. So this is the Twilight ACS. So ticagrelor with aspirin or alone in high-risk patients who after coronary intervention for ACS. So this was an ACS sub-study. High-risk PCI patients actually were now 9,000, and of them around 4,600 were ACS in this study. These 4,600 were again randomized to ticagrelor, aspirin versus placebo. This is a post-hoc analysis, and they they followed up these patients for 12 months to find again the same outcomes, the ischemic outcomes, the bleeding outcomes, and overall mortality in the two groups of patients. So these patients were not actually, all of them were not very simple patients. So you can see that around 60% patients in both the arms had multivessel coronary artery disease. Thrombus was there in around 15% patients, and calcification was there in 12% patients. Almost similar to what the populations we find in our overall PCI population. Total stent length was 40 millimeter, which basically means using maybe two stents, at least more than one stent in most of these patients. So these ACS patients were actually reasonably high risk patients. So graphical representation shows that death, MI, or stroke was similar in both subgroups. So actually, when you remove aspirin after 3 months from the dual antiplatelet strategy, you find no difference in the ischemic endpoints. It's not as if you stop aspirin and you will have more chances of MI in the subsequent 1 year. This is what this slide shows in the Kaplan-Meier curve. Bleeding, a vast decrease in bleeding. Removal of aspirin from the combination actually leads to a vast decrease from 7.6 to 3.6%. So your bleeding risk is almost halved. Hazard's ratio of 0.47. Bleeding risk is almost halved when you remove aspirin from the combination, which actually leads us to think that maybe it's aspirin which causes more bleeding compared to P2Y12 inhibitors. Of course, this was a subgroup analysis. It had some limitations because this was not this subgroup analysis was not done on STEMI patients. This was a non-ST elevation population, so you can't extrapolate the same results to STEMI. In STEMI patients, you continue with ticagrelor and aspirin for 1 year, no doubt about that. It can't be generalized to a broader population of patients without the high-risk features specified in Twilight. And of course, this study is limited to ticagrelor. It did not use prasugrel or any other P2Y12, newer P2Y12 inhibitor. And of course, there was lack of power to detect some clinical events such as stent thrombosis and stroke, which is a slight limitation of the study. Another subgroup analysis was Twilight complex study. So you might say that the patients who were taken up for Twilight did not have complex lesions. So that's why the Twilight complex study was also published. This was actually presented by Dr. George Dangus, again from Mount Sinai, a person whom I have the good fortune of personally knowing, and I'm acquainted with his work. So he presented this in the ACC 2020 World Congress. So subgroup analysis of complex patients were taken up for analysis. So you can see here that number of complex anatomies were there. So 19% had CTO, 10% had bifurcations, 6.9% had actually post CABG patients taken up for PCI. 15% were left main PCI patients, and around half of them had more than 60 millimeter total stent length, which means basically 2 or 3 stents were implanted. So a reasonably complex population of complex PCI was taken up for analysis, which basically means that this is not only a simple population that we are talking about. And in this complex population, when ticagrelor plus placebo was compared to ticagrelor plus aspirin, what does it show? Bleeding. So the topmost line is of ticagrelor and aspirin in complex PCI patients. The green line is ticagrelor and aspirin in non-complex patients. So these two groups had higher rates of bleeding compared to when aspirin was removed from the combination, whether it was a complex PCI or not complex PCI, as pre-specified as defined by the Mount Sinai investigators. Ischemic endpoints, again, ischemic endpoints, you can see the p-value 0.13. You can also see from this graph, all of these are relatively close together compared to the previous one in which they were very wide apart. Simply put, all these strategies, either including ticagrelor or including aspirin or excluding aspirin, did not have statistically significant difference as far as ischemic endpoints were compared. They were the same. Of course, what we must see is that the ticagrelor plus aspirin actually in this case had lesser causes chances of death, MI, or stroke. So pre-specified ischemic endpoints. So compared to using ticagrelor plus placebo compared to ticagrelor with aspirin, using only ticagrelor actually showed reduction in cardiovascular death, MI, or stroke. So the dark bar is of using only ticagrelor, and the white bar is using ticagrelor and aspirin. So there is a reduction in cardiovascular death, MI, or stroke. The hazard ratio is 0.75. Reduction in all-cause mortality, a hazard ratio of 0.59. Reduction in MI, 0.83 hazard ratio. And of course, a little bit of reduction in ischemic stroke. And of course, reduction in chances of stent thrombosis. So you can see that there is a reduction in almost all the ischemic endpoints. However, what has to be appreciated is that in this pre-specified subgroup of complex PCI patients, the confidence intervals are crossing over 1. So you can see all the confidence intervals are crossing over 1. So this actually decreases the strength of the statistical findings in complex PCI patients. So so the hazard ratios do not remain that strong. So this is one indicator that this strategy may not be for all patients. There are still There is still work to be done so that we can identify still specified subgroups where this strategy can work. So, however, they concluded in this sub-study that among patients who underwent complex PCI, as defined by a combination of high-risk features, a regimen of ticagrelor monotherapy after initial 3 months of dual antiplatelet therapy was associated with significantly lower clinically relevant bleeding without increasing the risk of ischemic events. This was consistent across all groups. So, to summarize, so this ticagrelor strategy is a new brave strategy which has come up. However, it still needs to be validated. It has not been incorporated in guidelines. To come to my last slide to summarize all the three studies that I put. So this is what I would like to you to use as a take-home slide. These are the points that you have to take home. Use of ticagrelor plus aspirin is definitely beneficial in PCI patients. In patients who have a history of PCI, either recent or remote, there is definite decrease in chances of MI or thrombosis. Of course, it comes at a chance of increased bleeding. A strategy of switching to clopidogrel for ticagrelor may be tried, especially in patients in whom you might find that feasibility because of economic or other reasons is not possible. You can go for switching over to clopidogrel with acceptable results. Of course, this strategy has not been validated in larger studies, but there is still evidence for that. Using a single antiplatelet therapy, surprisingly, only ticagrelor, not aspirin or prasugrel, after 3 months of PCI may be acceptable. This is the twilight strategy I was talking about. This can actually be especially used in patients with high bleeding risk, if not in the overall PCI population as of now. So if you have a patient who is at a high bleeding risk and you have done a PCI for that patient, you can use the twilight strategy to support your decision of stopping aspirin after 3 months and continuing ticagrelor with the expectation that you will reduce bleeding risk in that patient. Bleeding is still an issue. The more potent agents you use, bleeding is still going to be an issue. And of course, the other thing is discontinuation. So this is what industry needs to work upon, as well as we also need to work upon. Discontinuation is still an issue, so we have to bring down prices and we have to impress upon the patient that actually continuing with this therapy is beneficial economically in the long run, because the patient is prevented from further hospitalization or further procedures because of fresh events occurring down the line. So this is I would like to end with this slide, and thank you for your patient hearing. And we can have questions. Maybe someone can pass on the questions to me. Thank
Hello.
you.
Thank you, sir.
Yes,
Can we wait for 2 minutes for questions, sir? So any attendees have question, they can ask to you, sir.
right.
Hello.
Yes.
Sir, I think there are no more queries or confusion from attendees side. There is one message from Dr. Suresh. Thanks for this informative session. So, can I
Okay.
conclude or wait for a question, sir?
Yes, yes. Let's conclude.
Okay, sir. So, I would like to thank you on behalf of the organizer for your insightful and educated talk. Thank you, sir.
How many participants were there?
Sir, after the presentation, we can see the all attendees number. I will inform about the attendees number, sir.
Okay. Right.
So, thank you to all dear delegates and doctor for
Thank.
attending today's session. So, I am ending this session now. Thank you. Hello. Sir,
Yes.
there is one question from, just a minute. I am putting one question from Dr. Bina. Have you received the message, sir? I have put in the chat box, Zoom chat box.
Okay. So okay. So that's a very interesting, good question, good observation by Dr. Vinayak Rane. So yes. So he has asked that what do you feel about the recent approval for ticagrelor in the management of stroke? Yes, absolutely. So this is the Thales trial that you are talking about. Yes, it was published in NEJM recently, and yes, it's a very important new addition, important new indication, which has come up for use of ticagrelor. So what we have to remember is that it is for mild to moderate stroke patients in whom we can actually add ticagrelor to aspirin, and I think it's a very important trial and it's a very relevant trial. Why? Because many a times we have these patients who come to us with repetitive strokes and we don't know what to do with them. We do a Holter or some sort of monitoring to find out whether there is atrial fibrillation. If there is atrial fibrillation, we can start the patient on NOACs. However, if the patient is not having atrial fibrillation, what do we do? Do we keep the patient only on aspirin and wait for the next stroke to occur? So now we have actually some indication that maybe ticagrelor can work in these group of patients and can actually decrease the chance of stroke or TIA. So that is where I think ticagrelor can fit in the overall diagnostic, in the overall treatment algorithm for patients with recurrent strokes. So of course, if there are other trials which replicate this, and in trials which show that patients with recurrent strokes, we can use this combination, and that especially if they are in sinus rhythm, I think that will be an important addition to our treatment of these troublesome group of patients. So yes, I believe this is an important addition to important new indication, and I hope it finds its way into guidelines as well. Yes,
Thank you, sir. So, right now there are no more questions in the chat box, sir. So, can we wait or conclude, sir?
mm, I think we can conclude now if it is okay.
Okay, sir, no problem. So, I would like to thank you on behalf of the organizer for your insightful and educated talk and also question answer. So, I am ending this session now. Thank you, sir.
Thank you. Thank you.